Now I introduce Professor Ahmed Gawesh, who will talk us about a very important neglected issue. Also, it is very common. He will talk about phlebolymphoedema. Anything new?
Thank you, Mr. Chairman. Ladies and gentlemen, it's a great pleasure and honor to be with you today. And I would like to thank the organizing committee for their kind invitation and welcome you all to Alexandria. So this session is about lymphedema, and I will focus on a very specific type and special type of lymphedema, which is phlebolymphoedema. I have no disclosures related to this talk. So first I'll start with my story with lymphedema, which is actually, some of you might share the same story. When I was a medical student, I was told that lymphedema is an infection caused by Wuchereria bancrofti, which is a filarial disease that causes enlargement of the lower limb, causing a disease called elephantiasis. And that's what I knew when I was a medical student. And then when I became a vascular resident, I was told that it does not only affect the lower limbs, it can affect also the upper limb. And the most common cause is not filarial, but it's actually secondary lymphedema is more common, which is usually caused by cancer. So, and post-mastectomy lymphedema is one of the commonest that we see in the upper limb as well. And in both ways, I was told that this is what we can do. We can only compress, use compression therapy, use compression sleeve, use some lymphapress for that, and that's all what we can do for those patients. But then later on, when I started doing veins and doing the superficial and the deep interventions on the venous side, I was faced with some problem that after we do everything for some patients with venous disease, some of them actually have persistent edema in spite of treating all that treatable veins that can be treated. And that's actually not only our patients. Reviewing the literature, we found that in Raju's systematic review of more than 1,500 patients in which was treated with their venous system corrected by stenting, up to 35% of their patients had persistent swelling. And also, Enrico Asher in the US had the same result with stenting, ablation, and after even giving diuretics to those patients, 16% had persistent swelling after full venous correction. So what's wrong here? We're all aware about the classic Starling principle. The basis that we have learned in the physiology when we were students is that filtration on the capillary side occurs on the arteriolar side and reabsorption on the venular side, where veins carry the interstitial fluid out of the tissues. In 90% of that fluid goes to the veins and 10% goes to the lymphatics. We were wrong. Starling was wrong, because that was actually challenged about 12 years ago or so, 13 years ago, by the revised Starling principle, which showed clearly that using the glycocalyx model, that fluid doesn't pass except in one direction. It doesn't go out and then come back. It's actually always going from inside the lumen to the outside in the interstitial space, and it's only in one direction. And reabsorption actually does not occur in the blood vessels, but actually is carried out by the lymph in 100%. So the interstitial fluid, the filtration occurs in the capillaries, and the system responsible for removing the interstitial fluid is actually the lymph and not reabsorbed back to the capillaries. And that's a major change of our understanding about the problem. Because the clinical implications is tremendous, because lymphatic system is being responsible for 100% of the absorption of the interstitial tissue means that any edema is simply lymphedema, and that any chronic edema occurs due to lymphatic insufficiency or failure. We have the balance between the lymphatic load and the lymphatic transport capacity. Obviously, when the lymphatic load is more than the lymphatic transport capacity, then you get edema. And that can occur either due to the increased lymphatic load as in inflammation, and that's usually reversible with early treatment, But it can also occur due to destruction of the lymphatic transport capacity, and that's actually permanent when the lymphatic vessels are destroyed, like post-cellulitic, or as we can see in the venous side. So the second thing is that patients with CVI, especially those with C3 to C6, should be considered to have lymphedema. But that specific type is given the name as phlebolymphoedema. And that's the accumulation of interstitial fluid, which is full of proteinaceous material, but due to a venous cause. And that's where that name came from. And that was given by the guidelines published in 2022. And the thing is, phlebolymphoedema starts as due to increased lymphatic load, but then with the inflammation, fibrosis that occurs due to venous insufficiency, as well as if the patient gets on top infection by cellulitis with destruction of lymphatic vessels, it turns to be permanent afterwards with destruction with a mechanical cause as well for lymphedema. So what's interesting is that we thought that cancer was number one reason for lymphedema. However, this is an interesting study published that actually looked into patients with lymphedema in a cancer center, in a cancer-affiliated physical therapy center, and found that the most common cause was not cancer. The most common cause of edema was actually phlebolymphoedema. So phlebolymphoedema is the number one cause of lymphedema, not cancer, as we previously thought. So, speaking about lymphedema, the lymphedema also predisposes to infection because the presence of protein-rich interstitial fluid in the interstitial space actually encourages infection. So cellulitis leads to destruction of more lymphatics and decreased lymphatic transport capacity, so results in more edema, and we go into the vicious circle. And the CVI presents an excellent environment for that to happen. You have, besides the edema itself in venous disease, due to venous disease, you have the skin eczema, which can be a portal of entry for infection. You have skin inflammation already, and you can have a venous ulcer that also represents an entry point for infection. So there is no doubt that the presence of lymphedema predisposes to cellulitis and vice versa. And this is a database published of more than 85,000 patients with cellulitis actually were analyzed and showed that phlebolymphoedema had the highest rate of both initial and recurrent cellulitis in those patients. So that's just, you don't mix cellulitis with acute lipodermatous sclerosis that occurs in some patients with CVI, and also lymphedema rubra, because fever usually is present only in cellulitis. That's discriminatory. So what about the treatment? Lymphedema should be treated not by stockings, not by diuretics. Diuretics, just those two only shifts some water out, but it's not only about the water, it's about the proteinaceous content. So phlebolymphoedema should be treated, and lymphedema should be treated by complete decongestive therapy, including manual lymph drainage, exercise, skin care, as well as compression garments. That's the treatment. That pushes the protein-rich fluid back into the lymphatics. So now what? Now we know that veins and lymphatics overlap much more than we previously thought. Early treatment of venous pathology is important to avoid possible lymphatic load with lymphedema later on developing. And there is definitely a reason to treat advanced CVI patients before they develop cellulitis and inflammation and become more complicated with lymphedema on top. Besides that, treating the venous component only and focusing on it would be suboptimal, as we mentioned, that you will have some patients that are having persistent edema, whatever you do with their veins. And the second thing is that you have to incorporate lymphatic management as well in pre or post intervention to improve your outcomes. And that's actually clearly illustrated in those two very important publications in 2024. So to conclude, a management of lymphedema should be integrated in any modern phlebology practice as a multidisciplinary treatment. And thank you for listening.